For this segment of the program, I want to talk to you guys about a concerning health story that came out over the last couple of weeks, and that's involving these multiple drug-resistant bacteria, also called superbugs. And the most recent outbreak that we've heard about is at the UCLA Medical Center, the Ronald Reagan UCLA Medical Center. And at least 7 people, 2 of whom have died, have been infected with an antibiotic strain of bacteria called carbamazepine-resistant enterococcus. I know that's a mouthful right there. But basically, these patients were undergoing endoscopic procedures. So that's like where they have like a little cyber optic cable tube that goes down the throat and into the stomach and into the intestines. And it lets doctors and specialists look at those parts of the body to make diagnoses, to do treatments. It's a really common, it's a pretty common procedure. About 500,000 people in the United States undergo these kinds of procedures with these kinds of medical equipment. And you can imagine that it's really scary if you go to the hospital where you think you're going to be getting better if you're already sick, or you're going to get some reassurance that the problem that you're having is not as bad as you thought it was. To be infected from instruments that have been embedded with these infectious materials, it's pretty scary. And so a lot of this particular public health issue is within our ability to control. It's definitely within our ability to understand, but it is one of those things where we can't really just leave it up to the scientists and the infectious disease specialists. All of us are tied together in this web of mutuality to understand what each of us can do to prevent the rise of these multiple drug-resistant bacteria. And to help us get a better handle on this story, I'm really excited to introduce you guys to our next guest, Dr. John Powers. He is an infectious disease specialist. He is an associate clinical professor nearby here at the George Washington University School of Medicine and at the University of Maryland. I'm really excited to bring him on, and I just want to, make sure I introduce him the right way. And I've got, a little bit of time to talk to him before we bring him on the program. So just to let you guys know, he has had actually a lot of interesting work when it comes to this particular topic. Dr. Powers was the lead medical officer for antimicrobial drug development and resistance initiatives at the U.S. FDA. He was co-chair of the U.S. Federal Interagency Task Force on Antimicrobial Resistance. Prior to joining the FDA, Dr. Powers was assistant professor in the Division of Infectious Diseases at the University of Maryland School of Medicine, and he is still on faculty there. He also actively cares for patients weekly in clinic and attends a lot of the patients who are on the infectious disease inpatient service. He's been an investigator for over 50 clinical trials. He has particular expertise in the design, conduct, and analysis of clinical trials, and has published on various aspects of clinical trial design. He's won a bunch of awards. He's been nominated for the 2008 Distinguished Clinical Teacher Award by the NIH Fellows Committee, and he was the recipient of the 2010 NIH Directors Award. I'm really excited to have Dr. Powers on the program. I think that he's just the kind of expert that we need to wrap our minds around this this issue in microbiology and public health. And I think that it's the kind of thing where, the numbers, like I was saying before, they don't sound all that impressive, right? I mean, at UCLA, we're talking about, 7 people, maybe 8 people who've been infected with these, with these bacteria. But the thing is that, like, none of us should have to worry about this when we go to the hospital. And that's the reason why I feel this is a particularly important news story. And it's why, I want to cover this topic. So, so I'm really excited to have Dr. Powers with us. And Doctor, are you there?
Yeah, thanks, Saji. Thanks for inviting me.
Hi. Okay. So, thanks so much for joining us. This was one of those like very sciencey topics that I'm hoping that we can, wrap our minds around and bring it down to some brass tacks that our listeners can, feel like they can actively engage on, and that it isn't just for, brilliant scientists like yourself to work on. That it is actually a public health issue for all of us as Americans.
Yeah, absolutely. It is a problem that all of us need to tackle. And this issue with the endoscopes, I think, raises a lot of issues in terms of, first of all, you'd want to make sure that the people actually needed that diagnostic test to begin with. And secondly, that we need appropriate infection control processes to sterilize these kinds of things, which is another thing we often take for granted, is that, for instance, if you go into surgery, you're assuming that the scalpel that's going to cut you open has been properly sterilized. And that's really the issue here, I think, was one, at least with these endoscopes, of one of proper infection control. So it gets beyond just the usage of antibiotics, but even all of us can have an impact on this by not asking for antibiotics when we don't need them. And that's been an issue that's been around since penicillin was first discovered in the 1940s.
Right. So, why don't we look a little bit more into the kinds of germs that we're talking about, because I think that, we hear about, now it's CRE over at UCLA, but there's also VRE and MRSA and, a whole lot of this alphabet soup. So what kind of germs are we talking about? Like, what do they do?
Well, actually, the main issue here is not really about the germs. It's about the kinds of patients who actually get sick with these things. In December's Nature journal, there's a great article by Arturo Casadevall, which talks about, the title of it is Ditch the Term Pathogen. And what he actually talks about is that disease is actually caused by the interaction of one of these germs with the person's own immune system. In fact, most people don't realize that when you chew your food, brush your teeth, floss your teeth, that you can get bacteria in your bloodstream between 20 and 80% of the time. But that doesn't cause disease because your own immune system is capable of fighting those things off. What happens is when a person's immune system isn't functioning properly, for instance, in the types of persons that may undergo a bone marrow transplant, that get cancer chemotherapy, where the treatments for one disease actually affect the person's immune system, they then become more vulnerable to these kinds of infections. So it's a combination of not just superbugs, but not so super patients, people whose immune system isn't functioning properly. And I think that's really important because the vast majority of these kinds of infections do not occur in healthy people that are walking around on the street. They occur in people who have been very sick in the hospital for long periods of time, have gotten prior antibiotics. And consistently, studies show that again and again, receipt of a prior antibiotic, being in the hospital, being sicker to start with, is what predisposes people to get these kinds of infections. Yeah. There are some that occur in healthy people, such as what's this one called MRSA, or methicillin-resistant Staph aureus. But that brings up another issue, and that is methicillin is a drug that was discovered in the 1950s and hasn't been used for decades. Yet we describe these bugs in terms of their interactions with drugs that don't even exist anymore, and what happens to them in the test tube. What's really important that makes these things dangerous is not what happens in the test tube, it's what happens to patients. And so the issue of resistance is that drugs that used to be effective would be less effective in these situations where people are infected with these kinds of things. There are loads of bacteria that are present in the dirt outside your house that are intrinsically resistant to antibiotics, but they don't cause problems for people because they don't cause infections or because your immune system is able to fight them off if you skin your knee while you're out there doing your gardening.
Right. So it sounds like, I mean, I'm glad that you're helping us kind of like redirect our focus, towards helping the most vulnerable of our fellow Americans, when it comes to talking about this issue. But I am curious. I mean, you had mentioned earlier on about the way that we use antibiotics, even among us healthy people. I know that I have a lot of patients who, come into clinic hoping and expecting to be prescribed an antibiotic when I've heard that, up to 50% of the time our patients don't really need it. So, there is that role of excessive antibiotic use, but is it really limited to just like our clinical use, or are we talking about antibiotics outside of clinic too?
Antibiotics are used for all sorts of things. If you actually think about it, antibiotics are one of the only classes of drugs that is prescribed by all types of clinicians, from podiatrists to veterinarians to dentists, all over the place. Think about cancer chemotherapy. It's primarily limited to certain specialists. But the other place that antibiotics are used quite widely is in animal and livestock procedures. So, for instance, there are some 8 billion chickens in the United States. In fact, if the Far Side cartoons ever came true, the chickens would take over the country because they outnumber us logarithmically. But what happens is that these animals, when they ingest antibiotics, can then develop antibiotic-resistant bacteria in their intestines, and they leave that behind in the chicken coop for the next chicken to ingest, which causes a vicious cycle of resistant bacteria. Studies have actually shown that you can actually culture those bacteria off the chicken meat that's actually found in retail stores. So the use of antibiotics, which may be as much as 80% of antibiotics in the United States may be used in animals instead of in people, also contributes to this problem of antibiotic resistance.
Wow. So as much as 80%. That is amazing to me. Amazing.
Well, the problem is we can't get accurate numbers on that because the way the law is written does not actually allow FDA to be able to collate the information on antibiotic usage in animals so that we can actually even get accurate numbers, which is a problem in and of itself. You have to define the problem before you can do something about the problem.
Right. So, that's interesting to me. So, so does that mean that the FDA and the USDA, the Department of Agriculture, they're not talking to each other?
They do, but they actually serve different functions. And in fact, I think there's a move now to try to harmonize some of what each of these agencies do in terms of their approach to foodstuffs. But they do talk to each other. In fact, the USDA is a participant in gathering that kind of information on, what's found on retail meats. But the issue here is that FDA approves the drugs, but then has a limited capacity to be able to get back information on how the drugs are actually being used.
Okay.
So that issue is really an FDA issue, not a USDA one.
Got it. Okay. So, while we're talking about these government agencies, I was intrigued to learn that you are you were the co-chair of the CDC's interagency task force on antimicrobial resistance, and that task force actually has a public health action plan with a couple of areas of focus. Do you mind walking us through that a little bit?
Task Force Public Health Action Plan is a collaboration of, I think it's 11 different agencies throughout the U.S. government, and it has 3 different focus areas. The first of which is what you've already been talking about, surveillance, prevention, and control of antibiotic-resistant infections. And in fact, the endoscope issue you were just talking about certainly falls into that category. The second is research on developing better therapies to treat infectious diseases. And much of this has focused on developing the next antibiotic. But in fact, when you talk about antibiotic resistance, there's 2 words in it. The one is the resistance piece, which we already talked about means worse patient outcome. But the second part is antibiotic. And the part of this is that we have focused on the development of antibiotics for literally the last 80 years. And the question is, should we be doing research on novel treatments? For instance, using these little viruses called bacteriophages, which may actually attack the bacteria, and then once they've killed off those bacteria, they sort of commit suicide.
So you're talking about using germs against germs.
You got it, exactly. And when you think about it, who actually developed antibiotics was the germs themselves. Most antibiotics were discovered by being produced by fungus or bacteria themselves. So it's no wonder that they've been able to overcome them. After all, they invented them.
Oh, so you're talking about that story that some of us have heard in our first science classes about the fungus that actually developed penicillin and the scientists found it accidentally?
That's right. And in fact, cephalosporins were first discovered in sewer water off the coast of Italy. So you find these antibiotics in some odd places where the organisms themselves are making them. But working on things like drugs that may affect the human immune system to improve your capacity to fight off infections, drugs that may impact what's called biofilms, some of these organisms produce what's like a Star Trek shield that shields them from antibiotics being able to actually get to them to be able to kill them. If you can dissolve that biofilm or the Star Trek shield, the antibiotics may be able to work better, and thereby we may be able to improve outcomes for patients, but also preserve or prolong the usefulness of current antibiotics. So this research has to go beyond developing the next penicillin-type drug to getting into really novel things that may actually help. In fact, the very first treatments for infectious diseases in the early 1900s were vaccines and also an immune therapy called serum therapy, where the antibodies from horses were taken and injected into people with pneumonia, and it clearly saved lives, although it caused a lot of side effects. And so from 1910 till 1930, that was the primary treatment for pneumonia before sulfa drugs and penicillins were first discovered.
Interesting. So we're talking about, so you mentioned like the first two areas, the surveillance, prevention, and control of antimicrobial resistant infections, and the second area about how we actually research antibiotics and actually, look at like some pretty novel ways of thinking about our lives with germs. What's this third area that the CDC's task force is focused on?
So the third area is actually product development, and that is turning some of these research ideas, translating them into actual products that can be then administered to patients to improve outcomes for them when people are seriously ill with these kinds of infections. So there's been a lot of discussions about how to do that. There have been several bills put forth in front of Congress that attempt to streamline the way in which new treatments for infectious diseases are developed. And some of those, unfortunately, seem rather ill-conceived. They, for instance, allow a new antibiotic to get approved on less evidence, but which also may decrease our ability to tell whether the antibiotic even works to help people or not. There was a bill that was introduced just about a week and a half ago called HEAL, helping effective antibiotics last, which actually would focus incentives on drugs that actually have added benefits for patients. And that makes complete sense, that if we are going to streamline the regulatory pathways for these drugs to get through, we should be picking and choosing amongst the drugs and focus on the ones that actually have the most benefits for patients and allow them to get through the system faster. Some of the bills as they've been proposed would allow essentially any antibody to get through faster. And one, we won't know whether those things are actually beneficial for patients. And secondly, any kind of incentive program that gives every kind of drug an incentive isn't much of a program because it's not going to focus on what's really going to help people the most.
Right. Okay, so, those sound like some really important areas that the task force is covering, and I'm feeling a little bit more optimistic. One of the other things that I learned about, when we were looking you up as a guest was that you are the lead medical officer of antibiotic-resistant issues at the National Physicians Alliance, and now you're on the NPA's FDA task force. I was wondering if you could tell us more about your team's efforts.
Sure. I think I've sort of explained some of those. We actually have been working to try to support some of these bills like HEAL, which will actually, not only does HEAL have in it this issue of how to streamline the process for getting antibiotics to patients, it also has in it increased monitoring of antibiotic usage, what the drugs are being used for once they're actually being put out into the marketplace. And so we've been working on issues like that, and trying to actually help develop the evidence base from which physicians and patients can actually make better decisions. As you know, the U.S. spends the most for healthcare of any country in the world. In fact, if you would combine the next 10 countries on the list, we spend more than the next 10 countries combined, and yet we're something like 35th on overall healthcare. Now, that, by definition, means we're spending a lot of money on stuff that isn't really helping people. And so what our task force is actually trying to do is to help not only streamline getting medical interventions to patients faster, but to make sure that those interventions are actually better. So we want to actually, our NPA FDA task force is really trying to help FDA to focus on methodologies that may actually be able to get better therapies to patients, but still provide the evidence for physicians and patients that they need to know about these interventions. For instance, if you take the endoscopy issue that you just talked about, turns out that FDA knew about this as far back as 2009.
Oh, wow.
And, knowing about it and saying, well, we put out a warning. I don't know, Sandy, if you're a physician, do you know about this warning? I certainly didn't. And so there needs to be better communication in terms of what the evidence actually is. And again, for instance, this got a lot of discussion because it was infections with antibiotic-resistant organisms. Well, you know what? I'd be concerned if my patients were getting infected from an endoscope with antibiotic-susceptible organisms, too.
Right.
Because if we talk about the numbers, the CDC estimates about 22,000 people a year die from resistant infections. The Institute of Medicine estimates about 98,000 people a year die from medical errors.
Oh, wow. Yeah.
These kinds of things, using an endoscope which hasn't been sterilized could be conceived as a medical error. Giving antibiotics to somebody who doesn't need them could be perceived as a medical error. So many of these things are preventable if we take the right approach to these.
Yeah.
And that's what our task force is trying to do.
So, in these last couple of minutes, I was just wondering if you could, help us understand what we can do as individuals in our immediate day-to-day lives when it comes to this issue. A lot of us, we're still kind of in winter time. I have a lot of patients, you have a lot of patients who, really have looked at antibiotics almost like a dogma. What can they do? What can all of us do in our immediate day-to-day lives to, get a handle on all of this?
Yeah, I think the real issue that you can do on your day-to-day life is actually some pretty simple stuff. For instance, washing your hands. They prevent you from getting infected in the first place. Children getting vaccinated when it's appropriate. So, for instance, the measles vaccine is highly effective, and measles is a disease that's so contagious that if you're in a room with somebody with measles and you are not immune, there's a 90% chance that you will get sick. So in those situations, vaccination is appropriate. I don't want to sound like everybody should be vaccinated for everything, because there are situations where you can make a choice about being vaccinated or not. So, for instance, if somebody chooses not to be sexually active, the vaccine against human papillomavirus isn't going to do them much good. So there are some situations where vaccines aren't going to be that useful, but certainly in childhood diseases, we've seen a remarkable decrease in the incidence of these potentially lethal illnesses when the vaccines are very highly effective. The second thing is not asking for antibiotics in situations where you really don't need them. So when you get a cold over the wintertime, antibiotics are not effective in treating the common cold because those are caused by viruses, not bacteria. But even for some bacterial illnesses, antibiotics are not very effective. For instance, 3 studies over the last 7 or 8 years have shown that if you have an abscess that's caused even by MRSA, that once a physician lances that abscess and opens it up, the addition of antibiotics to that really offer no additional benefit whatsoever.
Interesting.
NIH did a study that was published in 2012 where they looked at people with acute sinus infections and gave antibiotics versus no antibiotics, and shows that the antibiotics didn't add anything in terms of people getting over the sniffles, et cetera, that they have from the sinus infection, yet it did cause more rashes and diarrhea. So what you're actually doing is you're hurting yourself by taking these drugs. You're causing more side effects you don't want, and they're not beneficial for people. So what people ought to be asking for is they show up at the doctor because they have some uncomfortable symptoms. Wouldn't it be much better to take symptomatic treatment that's actually going to help you feel better, and the rest of this stuff is going to go away on its own? And the other thing I think people need to do is to get educated about some of these particular infections. For instance, we published a study about a year ago where we looked at people, how fast it took them to get over pneumonia. It turns out that the cough, et cetera, gets better in about a week, but the fatigue lasts for almost as much as a month. Once people realize that, they're less likely to go back to the doctor and say, hey, doc, I still feel tired. Am I not over this disease yet? Do I need more antibiotics? So understanding the way that the disease actually affects you will also lead you to better understand that, look, this is just a part of this disease process. You're going to get better in a couple of weeks, and you don't need additional antibiotics for that.
Right. Okay, so it sounds like we've got some really good advice for our listeners. It sounds like, get educated, get vaccinated, and wash your hands, wash your hands, wash your hands. Dr. Powers, thank you so much for joining us today on the program. I feel much better about, my understanding of this issue. I hope our listeners do too, because, I think we live in a media that loves to, fearmonger, and perhaps that's not exactly the right prescription for this public health issue. Thank you so much for joining us, Dr. Powers.
You're very welcome. Thanks.
All right, and just to let you guys know, our listeners, we're going to have all of those resources posted up online. It'll be in the comments section of this YouTube clip and on our Facebook page. We're going to put it up on Twitter for you guys so you can learn more. And just like Dr. Powers said, get educated, get vaccinated, and wash your hands, wash your hands, wash your hands.